It is right at 2 p.m. Eastern. Thank you, everybody, for joining our lightning webinar today. As you know, we do these lightning webinars and other webinars monthly. We try to focus on topics that are of interest to our network and focus in the healthcare and telehealth industry. That is absolutely the case today. Well, we talked to Omar Badawi, who is a PharmD, Masters of Public Health, and also a fellow in the Society of Critical Care Medicine. We're honored to have Omar here today to talk about analytics, to talk about, as we titled this, Lost in Translation, how some of these predictive models may actually not work in real life as we look at how they're applied potentially theoretically and how they may not function in a real world scenario. So again, please add your comments, your questions into the chat or to the Q&A. We will be happy to answer them along the way or save them till the end. I know that everybody is excited to hear what Omar has to say. Is a lot to share today in this short period of time. So again, please put those into the chat or the Q&A. And with that, I will turn it over to you, Omar. Thank you.
All right. Thanks, Michelle. Yeah, so this will go pretty quickly. But what I wanted to focus on today is a bit of algorithms and the issue, one of the core issues that we see a lot when they don't translate well into the bedside. And I think anybody who's worked clinically in a hospital has likely experienced a decision support tool that was supposed to or promoted to be very accurate and to be something that would be easy to work with in their workflow, but it turned out being too noisy and too difficult to manage because of all the false alerts or alarms. So there's a lot of different reasons for that, but I'm going to talk about one specific pattern that we see quite often and something that can help you identify this, and maybe we can get into a little bit of how you can address it. So first, I want to talk about some of the key metrics. There's a lot of important metrics when you're building predictive models using AI from a user perspective, but I would argue that the two most important ones from a user perspective are going to be sensitivity and positive predictive value. So sensitivity is going to tell us which patients is this alert not identifying? You know, who am I missing, and how often is that happening? That's what we're always, concerned about, because you want to catch all the cases. And then the other is positive predictive value. Whenever this alert or tool comes up in front of you, what's the likelihood that that's actually true and representing a true positive case? If 1 in every 3 times it goes off, it's a true positive case, that's a positive predictive value of 33%. So pretty straightforward. But here's the thing about positive predictive value. It's really driven by the prevalence of the disease. So it depends how common disease is in your population, and that will actually drive your positive predictive value. So your same exact algorithm applied to 2 different populations that have a prevalence of disease difference, that will give you a different positive predictive value. And so if you have a lot of patients with a disease, then you get a high positive predictive value. It's more likely to be right. If it's rare, then it's more likely to be wrong. And that's with the same exact model.
And Omar, I know that you had some slides on that particular topic, so I wanted to make sure that we could all see them. If you were sharing them, I wanted to make sure that you had an opportunity to share them.
Right, thanks. Yeah, I'll come back to a couple examples at the end and show those.
Perfect.
Thank you. Yeah, so this has important implications because there's a variety of ways that you can deal with that and take advantage of it, or it can become an issue. But I want to talk about a common problem about how those models are made and how you can spot issues in publications that can help tip you off into how it might translate into your practice. So if we take everybody's favorite example, which is predicting sepsis, then let's talk about an example of if you want to predict or identify sepsis on admission into the emergency department. So if they come into the ED and you run a screening tool then you may have your data science team or researchers mine through your EHR, go through these records, identify your true positives, come up with a model, build it into your system. Obviously, you go through all this and then you use it, or you could buy something off the shelf. But either way, what you end up essentially having is a patient comes in, you have a set of data for that patient, you evaluate it once, and then you determine, yes, this patient has, criteria that we're worried about with sepsis or not. That ends up being relatively straightforward because you basically have a set of observations for that patient, and then that's it. There's no repeated measures that you have to be concerned about. Where it becomes problematic is in continuous monitoring, and that's an entirely different animal. So let's say you want to monitor in the ICU setting, and you want this model to be running all the time because you want to catch sepsis early, and you want to see when is it developing in patients. And so you're running it constantly, and that's in patients who are there for a short time, but also if a patient's there for 1 week, a month, or longer, this algorithm should theoretically be running all the time on that patient, right? And so those scenarios of how it will be used in clinical practice are critical for researchers to consider when they're developing and validating their models, because they usually won't build them that way. And what I mean is, when you're building these models, taking all of that data from every time period of every patient from within your hospital can become quite overwhelming. And sometimes there's some very good reasons why your data scientists may not want to use all of that data when building a model. Some machine learning models require there to be some relative balance between patients with and without disease. If your data set has extremely rare disease in it, then sometimes those models can come out biased and not work well in the real world. And so they want to rebalance that. And so what you'll see oftentimes is in machine learning literatures, they'll talk about rebalancing their cohort and selecting subset of data and then building their predictive models off of that. So that may be fine for developing the model, but where you get the big red flag is if that's how they validate it too. So if you're looking for something with continuous monitoring and you see in a paper or some promotional materials, any of these accuracy statistics, and they're based off of essentially patient level data, then that's problematic because you're not looking at one patient one time. It's actually patient time data. You have to look at that patient over and over and continuously. And so if the data is not set up that way and validated in that way, it really becomes very misleading. And so this is where I wanted to bring in the slides that will help kind of illuminate why this becomes an issue and give some examples.
Great, thank you.
All right. So with this screen here, this is just a scenario. We're going to go with some assumptions. Say you have 100 ICU patients and 15% of these ICU patients have sepsis on admission. Now, you've got this fancy predictive model that can identify sepsis with 90% sensitivity and 90% specificity. So it's a pretty darn accurate model. And you run this on this 15% of patients. Now, let's say you're just going to screen patients on admission. They come into the ICU and you're going to screen them. What's the positive predictive value of this? You can run through the math. I've done it for you. It's 60%. So it's pretty good, right? 6 out of 10 times, you're going to actually represent a real case. So now let's get a little more realistic, which is, if in the literature you see about 15% of ICU patients have sepsis, turns out on average, maybe about 10% of patients have it on admission, and the other 5 develop it later on in the ICU stay. So they come in with something else. Maybe it's an infection of lower grade, or maybe it's non-infection related and they develop sepsis later as a complication. But either way, you'd probably expect maybe about 10% of all patients having sepsis on admission. So take that same model, you only run it on admission, and what do you get for the positive predictive value? Still pretty high, about 50%. So not bad. 1 in every 2 alerts would represent a real case, and you'd feel pretty good about that. So again, that's pretty straightforward. On admission, kind of one time, how does that work? Now, what about the remaining 5 cases that develop it later? What is your tool going to do for them? And what, more importantly, what is it going to do for your users? And how are they going to be able to identify and help those patients? So let's say you've gone through admission, you've screened your 100 patients, you've found your 10 cases, and the other 5 don't develop sepsis until later in the stay. So right now, you have 90 patients without sepsis and 10 with sepsis that have been identified and are being treated. You don't actually run your model on the treated patients anymore, right? There's no value there. You're running it to identify unrecognized cases. But as you can see, there are no unrecognized cases. The other 5 haven't even happened yet. So at this point in time, there's literally no cases to find, but your model is still going to be running. And so all you can get is false positives, right? Because there's no true positive cases. So you can see that becomes problematic right away. But then what happens is, as time goes by, maybe it's hours, maybe it's a day, of those other 5 cases that are going to develop, one of them starts to develop the signs and symptoms associated with it, and they're going to have sepsis in the next 6 hours. So now you have 1 in 90. That ends up with a prevalence of about 1.1%, okay? And then what happens is, okay, there's nobody, now there's 1. You run that through, what's that positive predictive value? 8%, okay? So a lot of false positives. And then what happens? You find that patient, you go, okay, great, we got an early identification, we find them, and you're basically back to, okay, now nobody has it again, right? And now you're down to 0 out of 89 until the next blip. So so that's really, those are the examples I wanted to share. And this is why it can become problematic when you are reading literature and going through cases, because what you really need to do is set up your data, and the researchers need to set up their data and validate in a way that represents what happens in the real world of continuous monitoring. And then you need to develop, there still may be value. People may say, well, there's no value in an alert that only has a PPV of 8%, but there may also be things you can do there that derive value out of it. You just have to create a different workflow, because bedside clinicians should not be inundated with this, and it's not going to be valuable at this level for a bedside clinician to be interrupted this often for something that's rarely correct.
I think that's one of the key points of it, right? These are alerts that create overwhelming alert fatigue. So making sure that you're focused right on exactly what it is that you want to be able to identify, and identifying it accurately on a level that you're pointing out here is so important. I did share in the chat an article, a publication that you participated in the study along with one of our consultants as well, Teresa Rincon, on the evaluation of evolving sepsis screening criteria and just determining suspected sepsis and mortality among adult patients admitted to the intensive care unit. And my understanding from that article is you're using some of the logic that you are presenting here today, and how that can help with evaluating patients with sepsis. Would you, not to derail you, I'm sure you had a discussion about that. Would you like to speak at all about that publication and give any framework or context?
We've had a few different research activities we've done in this area. This one in particular was really looking at some of the evolving criteria between SIRS, sepsis 2 and sepsis 3, and then some other modified versions that could be applied and how those differ in terms of identifying cases. And it was primarily looking at patients on admission and just some of the variety of definitions and what would happen there. So that's it's a good topic, but it will be a little bit deep to go into.
Oh, absolutely. Yeah, not for our 15 minutes. I know that we're right on the 15-minute mark, but I do want to allow anyone that may have questions in the chat or in the Q&A to ask any questions to you, Omar. I know these are weighty topics. These are heady topics around analytics, and probably aren't doing it any justice in 15 minutes, but it gives us a flavor for it. And then we can do a longer topic on this, do a longer session on predictive analytics and alert fatigue in the future. But we think this would be a good way to start that. So I'll allow anyone to put any questions now or to speak. If you choose to, you could raise your hand as well, and we can open your mic if you would like to ask a question directly. One of the things I know that we talked about was around these predictive models and really how you can utilize them, not just in sepsis, but also in some of the head-to-bed evaluation and some of the other clinical alerts. What have you seen, and what's the impact beyond sepsis, which is of course very important, but anything beyond that?
Yeah, it's a great question. I mean, really, this concept, we just see it happen over and over again. It really has a big impact when we're talking about one-time evaluations versus continuous monitoring. And you can think of, when checklists started coming around as something to be really useful for improving quality, those are actually really great for one-time things, right? That came out of the airline industry. Like, before we start the plane, we're going to go through a checklist. It works really well in surgery. Before we start surgery, let's go through the checklist. People tried to adopt it in the ICU and say, okay, let's check our vent bundle with a checklist and look at head of bed elevation. Well, that's a dynamic thing that's changing all the time. Maybe not all the time, but it changes. And so as soon as you go through your checklist and say, yes, the head of bed is elevated 30 degrees. Once that changes, are you checking again? Who's continuously monitoring? And it's a different workflow that needs to be considered. You can't always translate every kind of screening tool for any use case. You really have to think through the implications of that.
Yeah, good point. Good point. I know we mentioned at the beginning of this, and you accepted it, or when we started the webinar, that this webinar has been recorded. So if you'd like to come back and listen to it again and potentially ask Omar any questions post-webinar, or forgot something that you meant to ask, or are working on a topic yourself and you just want to get some advisory help or some assistance with that project, please let us know. Certainly we'll do a longer session on this topic. I think there's a lot of interest in what we're doing. We had quite a few registrants for this webinar, so we're interested to do some more modeling and more discussion on data analytics. And we appreciate and honored to have you share your knowledge today, Omar. We really appreciate that. And thank you so much for your attendance for those participants here today. Thank you.
Thanks for having me.